Question third, a 34-year-old prima gravida woman presents to the obstetric clinic with chief complaint of painless vaginal bleeding. She was diagnosed with placenta previa and transfused 2 units of whole blood. 5 hours after the transfusion, she developed fever and chills. How would the current situation be prevented? So this condition is prevented by transfusing leukoreduced blood product, and this patient is classically having febrile non-hemolytic anemia. You can see certain features in this patient so the time of the onset of this transfusion reaction is 5 hours. So within 5 hours you can either have IgA anaphylactic reaction or acute hemolytic reaction or febrile non-hemolytic. Okay, IgA usually presents with having anaphylaxis. They can present with urticaria, or they have hives and they have itching. So this can be ruled out basis on the symptoms. While acute hemolytic anemia, the patient have worse symptoms than the patient here. And here we can have febrile non-hemolytic anemia, which is usually due to cytokines that are in leukocytes, and this can be reduced via transfusing leukocyte reduce, or we can reduce the number of leukocytes into the blood sample, and this can decrease the febrile non-hemolytic reaction. Okay, let's discuss this. So this patient is presenting with febrile non-hemolytic reaction, and that is the most common reaction. So it's very common, and the cause of this reaction is it's caused by cytokines from the donor's leukocyte. The patient who is so the donor who is giving leukocyte to the receiver, so the cytokines are activating the complement pathway into the receivers, and that is causing this kind of reaction. So we can remove these cytokines by decreasing the number of WBC into the blood transfusion. So the signs and symptoms are patient having fever and chills within a few hours of transfusion. Patient have nausea, vomiting, and hypotension. Action is to discontinue this transfusion. We support and monitor, and okay to give the next transfusion if there is no hemolysis, and we can decrease the incidence by leukoreduction. Okay, and certain type of transfusion reaction we have to see. The first type is most common that we just now discussed is non-hemolytic transfusion reaction that usually presents in first 1 to 6 hours of transfusion. Usually symptoms are fevers and chill, and it is caused by cytokine accumulation during the blood storage. Another one is acute hemolytic, that is fever, flank pain. The most common sign in this acute hemolytic is hemoglobinuria or flank pain that is caused by acute renal failure or acute kidney injury due to the RBCs that are lysed or hemolyzed. This patient also presents with DIC-like symptoms like oozing of blood from the transfusion syringe. So you can see DIC-like symptoms, and they can also present with DIC. It presents with in 1 hour of transfusion. The patient have positive direct Coombs test, and they have pink plasma, and it is also caused by ABO incompatibility. The delayed hemolytic reaction is usually with mild fever and hemolytic anemia, usually within 2 to 10 days of transfusion. They also have positive direct Coombs test and positive new antibody screen. So what do we do when there is this kind of transfusion reaction that are occurring? How could we prevent in the next transfusion reaction of this patient? First of all, we can do is irradiation, or we decrease the in certain transfusion we can do irradiation, like in bone marrow transplant recipient or acquired or congenital cellular immunodeficiency patient, or blood component that is donated by first or second degree relatives. We can irradiate the RBC. Leukoreduction is done in this febrile non-hemolytic reaction, which is seen also indicated in chronically infused patient if they are receiving chronically transfusion of the blood. So we make sure that blood is leukoreduced. We also give in CMV seronegative patients, like in AIDS and transplant patient. We also make sure to have potential transplant recipient, and if there is a previous febrile non-hemolytic reaction, we make sure to do leukoreduced RBC treatment. Also, there is a type of treatment, washed RBC treatment, that is usually given in IgA deficiency, or also in complement dependent autoimmune hemolytic anemia. And there is a continued allergy reaction or hives with RBC transfusion despite of antihistamine treatment. So whenever there is allergic reaction, we wash the RBC. Acetaminophen and antihistamine pre-medication can help to prevent febrile non-hemolytic reaction.
Thanks for watching. Please give a thumbs up and subscribe for more.